Hey friends, Kambria Evans here with the Zero Disturbance podcast, and we are rocking and rolling through our latest series, Dumb Things Therapists Say. And the spirit of this series really is to talk about the lifelong learning that we as therapists do through our clinical practice and our experiments with clients and all the trainings we go through. We're constantly integrating, relearning, rewiring our own understanding of how to serve our clients most effectively and efficiently. And this also is a series for people who are in therapy to understand your therapist might say something dumb to you because your therapist is not perfect. And I want to empower people to understand that you as a client in therapy can use your own discernment and your own clinical reasoning brain to make choices that serve you. And that's really, really what I'm trying to do. I've been training therapists for years. And really want to speak to everyone now about how to make choices that work for you and empower yourself. So with all of that said, let's dive into today's topic. Today, we're talking about dumb things therapists say around using EMDR versus talk therapy, right? There's this question of like, is this person ready for EMDR? You should do talk therapy instead of EMDR. And I just want to blow all of that up. And I'm just going to give you my opinion now, which is that everyone should be in a brain-based therapy, period. I don't care if it's brain spotting, EMDR, art. I don't care which one it is. I'm not here promoting like a specific one. Now, as a client myself, I do EMDR and brain spotting, and it's amazing, right? So I do combine the two in my practice here in California. But what's important to understand is that talk therapy is important. And I want you to understand a couple of things today. One, what is happening in talk therapy? Like, what are we doing? Why are we saying you should do talk therapy versus EMDR? Like, what's the differences? Why are we saying that, right? So what's happening in talk therapy and what's not happening in talk therapy? This idea that EMDR is only for certain people, meaning like saying there's only one way to do EMDR. It's kind of like saying, we shouldn't go to Baskin Robbins, right? Because you don't like that one flavor. There's like 32 flavors, right? There's so many variations in EMDR of the standard protocol. The standard protocol was made like over 40 years ago. And so when we're talking about what EMDR is, especially when we're making choices about what it is compared to talk therapy, right? It's important to understand, like, what are we saying? What are we choosing or not choosing? What are the choices available to us? And I'm going to talk about that today so that you can feel powerful to say smart things and make smart choices, whether you're a therapist or a client in therapy, okay? Okay, so let's think about this question together. What's happening in talk therapy? Okay. And before I go into this, I want everyone to understand that I oftentimes will work as an adjunct EMDR intensive therapist, meaning that my clients come in for focused specific EMDR treatment and they have a talk therapist who is supporting them, right? So what is that talk therapist doing in an ideal world? They are helping them to rewrite a narrative that they have already worked to understand, meaning Maybe I'm going into therapy to work on my relationship with food. And my talk therapist can help me understand, well, here is what my relationship with food looks like. Here's the narrative around what's happening to me, right? For me. Here's someone to show me with a mirror to see myself clearly. That's important. That's super, super important. Now, the talk therapist can also help a client understand their goals, meaning, okay, here's what's happening now. What do you want to have happen, right? This is basically like phase one of EMDR. It's just history and assessment, right? And then there's some phase two of EMDR around resourcing. So talk therapists also can help resource a client, right? And even a coach does this too. Like, are you taking care of yourself? Do you eat food that your body responds well to? Are you sleeping? Do you have a social support system around you, a community, a container of safety outside of our therapeutic relationship? These are all things a talk therapist can do to support somebody, right? Now, here's where it gets a little nuanced. there used to be this therapy, and maybe it still exists, called exposure therapy. And the idea of exposure therapy was, we're going to expose you to something that scares you because we're going to desensitize, right? We're going to desensitize that fear by just exposing it to you over and over and over again. Because if you see something over and over and over and over again, the impact is less. Is this 100% true? I don't know that I'm necessarily convinced of this, right? I see people come in with seeing lots of traumatic things over and over again, like physicians during COVID. Did they become desensitized to that? I think they just found a way to dissociate and put it away somewhere, kind of, but it spills over, right? So exposure therapy is this idea that if you come in and you face something, it's going to desensitize. Now, in talk therapy, what are we doing? When we go into talk therapy and talk about something traumatic, right, something upsetting, we might get connection and safety and a container. We might get the present safety of now with our therapist, which is beautiful. And that does take the edge off of disturbing things. It allows us to say certain things, right? And also what might be happening when we leave out the body, like EMDR takes the body with us, when we are only using cognition or we're only talking in talk therapy and we leave out the body, what we're doing is we are basically activating and lighting up memory networks, right? If you go into therapy, talk therapy, and you're talking about your childhood over and over and over and over and over again, you're lighting up that whole memory network, lighting it up like a Christmas tree. You're taking it from the back burner and you're putting it on the front burner. And maybe it's coming in on a scale of 0 to 10 for disturbance. Maybe it's a 10. And you're just emoting and you're processing, right? And maybe you leave and you're like, oh, I feel a little bit better. But maybe I'm just kind of sick of talking about the same thing all the time. It still sucks. This still sucks. Maybe it went from a 10 to like a 7, which is great, which is so great. And I love that people can have that experience, okay? But here's why I want to convince you of something different. You're going 5 miles an hour when you're doing it that way. You just are, okay? We have brain-based therapies that can do all that, plus incorporate bilateral stimulation in the EMDR protocols and different structures to accelerate that. What am I talking about? I'm talking about we can accelerate going from a 10 out of 10 on the disturbance scale down to like a 2. Like we can accelerate that faster. What does that do? Well, it saves you lots of energy and emotion. Saves you lots of money. Therapy's not cheap. And saves you lots of time, right? And it also creates a sense, I think, for people of hope and power, that they can choose things that allow them to do that so quickly and effectively and efficiently. It's kind of like feeling like you have a cape on, I think, for a lot of people. And your body feels different, right? So there is a difference in decreasing the disturbance. There is a difference in terms of time, right? And there's a difference in terms of just the process. Like any process we go through, we're deciding something about ourselves. If I go to talk therapy for 5 years or 10 years, which I've done before, I knew about EMDR, and I'm working on something and working on something and working on something, I might decide I'm committed to myself. I love myself, right? I also might decide I don't feel very strong and capable because I'm talking about this every single week. And it's like, what's different? What's different in my life? Am I choosing better partners? Am I feeling like I have more self-esteem? Kind of, but it's just not satisfying enough. Okay? Okay. And here's what I want to say about the talk therapists or even physicians who tell their patients and clients that EMDR is too much. It's too much. What I want to say is that when we talk about what EMDR or any brain-based therapy can do or is, it's not one thing. And I'm gonna go into that. And the reason why I think that's a disservice is because it's A, not accurate, but B, also there's this underlying idea that go ahead and just wait. And you can take this disturbance, you can take this trauma, and you can put it away. You can just put it away. We can contain it, compartmentalize it, put it over here. No, you can't. No, you can't. You can try. You can try. There's this idea that I think that talk therapists say, that even physicians tell their patients who come in with somatic symptoms, that you can put something away. Like, oh, maybe you don't need to do EMDR right now because you can just kind of put this thing over here and put it away. Now, we've seen with PTSD, we've seen with different symptoms that you can try. You can try to put it away, right? You can try to take all that disturbance and put it away. You can try to ignore it in your body. But what are you doing? You're disconnecting from yourself, right? Which gives you safety and protection. But guess what? We can't necessarily choose what we're disconnecting from. So when we choose to dissociate from something or put it away, we're dissociating from most of our other body parts. We're dissociating from most of our other emotions. We're dissociating from our life. And that makes me really, really sad as an EMDR therapist to know that people are not choosing to do brain-based therapies like EMDR because they think it's going to be too intense or too much, or they can put it away. They can put away their disturbance, or I'll just live with it. I'll just live with it. And what a life to live, to think that I'm going to go to like 80 or 90 years old and I'm going to have chosen for decades to live with panic attacks, to live with anxiety, to live with this underlying malaise and depression and negativity, because I just thought to myself, I'm just going to put it away. I'm just going to have it be part of my programming, my wiring. And this acceptance of this, right? This decrease in quality of life, this decrease in this ability to access ourselves. The fact that we're choosing this makes me so sad because it can be so different. It can be so, so different with brain-based therapies, okay? The metaphor I was trying to think of to make this kind of clear was around medical care, right? So some of us have medical issues and we have to get procedures, right? I might live with endometriosis and like severe menstrual cramps my whole entire life. I might spend 25% of my life, right, in pain, medicating, just pushing through, right? A lot of women choose to do this. It's not wrong or bad. It's just an example. Or my doctor might say to me, you know what? Let's just do a hysterectomy. Let's get it out, right? Let's take care of it. Now, this is kind of like what people say when they say, like, let's do EMDR for your trauma. It's like, whoa, that's a lot. Getting a hysterectomy is kind of intense, right? That's a big surgery. Okay, is there another thing we can do that will resolve this, right? Your physician has multiple treatments to help you get rid of something that's bothering you, right? It can be a surgery. It can be a procedure. It can be inpatient, outpatient. Like there's tons of choices to alleviate symptoms in the body and pain from medical issues. The same is true when it comes to your mental health, which, by the way, does impact your physical body 100%. Okay? Even if you're dissociating from your body still has body sensations. You're just not feeling them. Okay? The body's always part of this. So I'm bringing this up because this idea that there's one way to resolve something when it comes to medical care is kind of silly. And the idea that there's one way to resolve trauma or disturbance in therapy is kind of silly, right? And just because we have this idea that EMDR is for trauma, because the research says that, right? And it can be for what the DSM and insurance companies need to call mental illness or mental disorders, right? What we actually know is that EMDR and other brain-based therapies can rewire the body. Okay? So the question I often tell people when they contact me is, do you want to take care of this like at the root and we're done? Like, are you ready to do that? And then I ask them a second question, which is, how do you want to do that? And I give them choices like a menu, okay? And I'm going to tell you what my menu options are so that if you're a therapist listening who does brain-based therapy, you can tell this to your clients too. If you're a physician someone's coming in with migraines or TMJ, you can give them the same menu of options when it comes to brain-based therapies, okay? Or if you're a talk therapist and you're like, this is kind of taking the edge off, but maybe I need to have someone work with me as an adjunct brain-based therapist, an adjunct EMDR therapist to help this person actually find some significant relief, okay? Even as a client, this is really confusing. It's really confusing to think about, well, how do I know if I should do EMDR or brain spotting or art or flash or 4 blinks or EMDR 2.0? Like, even therapists are like, how should I get trained? So I'm going to just break down for all of you the menu that I give people who contact me, okay? Standard EMDR protocol. It's what we all learn in basic training. And guess what? It's not enough. Because what the standard basic training tells you as a therapist is when you think about your target trauma memory you want to desensitize, you want to go to the first or the worst. Now, here's the thing. Most people don't have the resources or the tolerance or the skills yet to go to first and worst. And guess what? When you set them up to do that, you freak them out. They don't come back. They think EMDR doesn't work. It's too overwhelming because you haven't prepared them. You haven't given them choices about what target to choose. And just because we know as clinicians that first and worst is the source of the coding and the programming, you don't have to start there. Why wouldn't you give somebody a positive experience of EMDR first by choosing something that's like a 5 on the disturbance scale of 0 to 10? Don't start with a 10 out of 10. What are you doing? I hate that basic trainings teach people this. I think it's so unethical. Quite honestly, I think it freaks people out. So that's standard protocol. Okay, we have so many other things, you guys, right? We have standard protocol with EMDR, but don't start with a 10 out of 10. Start with a 5 out of 10. Start with a 4 out of 10. Just give somebody an experience, right? People will oftentimes come in and if they have a compulsive behavior, I'll use a protocol that's for addiction and I'll say, let's do a feeling state addiction protocol by Robert Miller. And let's go ahead and just give you an experience of how things are linked and how you process with me, right? Let's take your addiction to eating and the positive feeling state of feeling comfort. And let's just kind of notice how your brain delinks that together. We haven't processed any trauma. We're going to bump up against something traumatic, and that will tell us what the target is, right? But we're not starting with first and worst because I want you to see what it feels like to be with me. I want you to notice yourself when you do EMDR. There's a lot of learning happening here, a lot of safety, okay? So there's not just one way to do EMDR. Some people come in and we only do phase 2, which is resourcing, which I describe to my clients as doing like a spa day for your brain and your body. We're just picking positive resources already in your brain, and we're just pulling them out, and we're using the bilateral stimulation, and we're expanding them. It feels so good. Nothing traumatic is happening. 0. Okay? That can just be used to stabilize somebody having a hard time. We're not processing trauma in phase 4 yet. EMDR has so many phases to it. Okay? All right. EMDR 2.0. What is the premise of that? I love this protocol so much. Basically, it's like you intentionally activate and trigger someone, which brings all the material to the front burner, right? You make them talk about it. You bring in props to trigger them. You even have their body in certain positions to like have their muscle memory activated. And then you use BLS, right? In like different ways, working memory tasks to intensely desensitize it. How smart is that? But guess what? Not everybody wants to do that. That's intense, but it's impactful, right? What is brain spotting? Brain spotting is here's a trauma spot, here's a resource spot. Did y'all know that you can process something disturbing from a resource spot? You can actually process, because it's in the periphery, it's still there. It's incredible. And I think that the Flash and 4 blinks, right? So that's Flashes with Phil Mansfield. 4 blinks is with Tom Zimmerman. He's amazing. He's been on the podcast. He's great. Both of these techniques, which by the way, you can go learn how to do on yourself, require you to pull in a resource to focus on that as the target. And then there's something disturbing being processed over here. So you're resourcing yourself intensely, which is kind of the opposite of focusing on a trauma target like we do in standard protocol, right? First and worst. We're focusing on a resource. It feels good. We're using our eye movements to blink, right? 4 blinks with Tom Zimmerman does this. And then you're desensitizing something at the same time. It's amazing, right? It's amazing how we can choose what we focus on to help us decide how to decrease disturbance and build resources. This is what all of these brain-based therapies have in common. They're all using the same idea, which is why it saddens me when someone says, oh, EMDR is too intense. Brain-based therapies are too intense. There's not enough information out there for people to understand what exactly we're talking about and how these modalities can be used. Okay? So my hope in talking about this today is that people will say smarter things, that we will share information about what these brain-based therapies can do, whether we're in a hospital clinic, whether we're in a talk therapist room, whether we're just sitting on our couch on the internet like, I want to feel better. How do I do that? Right? I just want people to understand what it is they're actually choosing and what choices are actually available to them. Okay? And y'all, if this is exciting to you and you're feeling motivated and powerful about what you want to do for yourself and what you want to do in your therapy or with your coach, we do have our client workbook, which has over 3 hours of supportive videos for you. It's available now. This is a culmination of 10 years of my clinical work here in my office in California with my EMDR and brain spotting patients, as a client doing EMDR and brain spotting on myself, and also just on all the consultation I've done with all the therapists that have come to work with me to get guidance and mentorship about how to serve their clients. So if that's of interest to you, there is a link below to the client workbook. I hope that feels like it serves the need that's out there, because there's not enough brain-based therapists. There's just not enough of us. We can't get trained fast enough. And so I'm excited that things like brain spotting, 4 blinks, these are things you can actually go learn how to do on yourself. Now, I don't recommend processing trauma by yourself. However, these modalities teach you how to resource yourself and take the edge off of things by yourself, which I think is so exciting and so powerful for people who can't access brain-based therapists because there's not enough of us. And there's just not people who necessarily can afford therapy right now. They don't have the time, they don't have the resources, and so there needs to be other options. And guess what? There are. So exciting. So I hope today's episode has been helpful. Y'all know that I really, really feel passionate about making sure people have what they need to feel better. So I will look forward to being with all of you next time in our next week's episode. And until then, be well.